and share a little bit about the historical context that led up to today's webinar, as the state really has a long history of working to try to move person-centered care from theory to practice. And that history can get traced all the way back to the early 90s and the Thomas S. class, the class action lawsuit, which really focused on the needs to use person-centered care and planning as one tool to protect the rights of people to really transition out of institutionalized settings into their least restrictive environments in the community. And then in the 2 decades that followed, the state continued to build on that effort and to develop new tools, such as the 2010 PCP manual, and to incorporate new ideas, such as the wide range of person-centered practices that emerged out of the mental health recovery movement. But despite that progress, some ongoing quality reviews indicated while there had been improvements in a number of areas, the state was not yet where it wanted to be in terms of universal and consistent implementation of person-centered planning. So to address that issue, a diverse multi-stakeholder work group, including people and families with lived experience of disability, was convened to work together over a number of years to revise and update the original PCP manual. That ultimately led to the creation of the most recent North Carolina Person-Centered Planning Guidance document, which became effective just about a year ago in November of 2023. And that document clarified quality standards and offered a suggested planning template to really facilitate the uptake of PCP in the field. And to further facilitate that uptake and to help people to meet the standards and expectations in that guidance document, a 4-hour introductory training on person-centered planning was developed and delivered multiple times in 2022. And ultimately, we recorded that and made it permanently available on the UNC Behavioral Health Springboard platform, the BHS platform. And Ingrid's going to drop a link both to that guidance document and to the BHS training into the chat box for us. Note that with the implementation of the guidance document, the 4-hour training is required of all providers who work in programs that include PCP in the service definition. And between our 2022 live trainings and those who have taken it on the BHS platform, I think we're up to over, at last count, over 10,000 people who have taken that training. So if you have not already done so, we really encourage you to check it out. So again, please see the chat box. And then finally, I would say that, the state does recognize that the field needs ongoing support and resources to advance in PCP implementation. And so to that end, there's a variety of things that are in the works, including a regular webinar series this year that I'm coordinating on hot topics and frequently asked questions around PCP practice. Before I tell you a little bit more about myself, Leigh Ann, Amy, and I are all going to do that when we sort of step into our section of the presentation. It's helpful for us to get a sense of who all is in the room with us. So I'm going to go ahead and I'm going to open a poll just to get a sense of who's in the audience today, because that's then going to really help us sort of get a sense of your perspectives and maybe tailor some of our remarks to better meet your needs. So if you can go ahead and complete that, be great. And when you're done completing that, since this is a person-centered care training, we always like to do something a little bit fun and personal on the front end. So if you could tell us in the chat, if there is one person that you could share a meal or a conversation with, any one person, current or historical, who would that be? And we'll just be curious to see some of your responses there in the chat. I'll volunteer my own while you all do that. I'm currently coming off of Olympics fever, and I'm obsessed with Simone Biles, and I just think she's done amazing things for women's sports and sportsmanship, and most of all, mental health. So I think that would be terrific. So that's one example I had floating around in my head. All right, let me end the poll. Let me share results. All right, terrific. So we've got a pretty diverse group of stakeholders with us today, lots of direct support practitioners, got advocates, people with lived experiences, representatives from our tailored plans. Okay, terrific, terrific. Let me, Ingrid, go ahead to the next slide. And I'll tell you a little bit kind of about me and the perspectives that I bring into the training today. So you can read a little bit more about my professional background here, but I'm a clinical psychologist. I'm an associate professor at a place called the Program for Recovery and Community Health up at Yale University. I've been here for over 20 years now, and I started out my career in the broader disability rights movement, and I've continued to do some cross-disability work over the years, but more of my recent work has been in the context of mental health systems transformation. But really the common thread throughout all of that is I'm very passionate about kind of the translation of person-centered values into person-centered practices. So in my day-to-day, I do research on that topic, I develop curricula, and I do lots of training and consultation at the practice and systems level around the country. But I'm also passionate about this topic from a personal perspective. I kind of enter into this space also wearing the hat of a loving mom of an autistic young adult who's also struggled really mightily with mental health issues as a sort of a consequence of being neurodivergent in a very kind of neurotypical world. And, you know, I've seen kind of the healing power of person-centered care in my own family when it saved a family member's life over 30 years ago when he sustained a TBI in a pretty major motor vehicle accident. And person-centered planning couldn't give him back the use of his legs or his speech or his vision, but in many ways, it genuinely gave him back his life. So this topic resonates with me on a number of levels. So thanks again for joining us. We're really thrilled to have such a great turnout. And with that, we're going to go to the next slide. I'm going to give you a brief overview of what we're going to cover today. So Justin and Robin have already covered some of the history and the background for us. Leigh Ann and I are going to tackle some different aspects of quality crisis planning, including things like framing the problem, addressing common challenges, sharing some general best practices, but also we're going to speak directly to some tips for completing your specific crisis planning template that's required here in North Carolina. Amy is going to offer a very powerful example from her own lived experience, how a person-centered crisis plan kind of came together for her, how it impacted her recovery. And we'll save some time at the end to briefly share a couple of different examples about what it might actually look like and how it might come together in a template for a few folks that we call Roma and another that we call Fred, and leave some time for Q&A and wrap up an evaluation, and I'll give additional housekeeping and reminders about the evaluation when we get to that point. Next slide, Ingrid. So there's lots of PCP models and tools dating back over 3 decades across a wide variety of service populations, including here in the state of North Carolina. So in addition to the renewed focus on PCP through that statewide work group and guidance document that Robin and Justin were talking about, there's a long history across the system, for example, of person-centered thinking, training, and applications from the learning community for person-centered practices. That's a graphic on the bottom left of the screen up there. Others come out of the Charting a Life course model, some of the work that we've done in the mental health space around the recovery roadmap curricula. The important thing really we want to make sure that people remember is that while there's a multitude of different models and tools that are out there, some may have been applied more consistently with certain populations or with youth versus adults. They really all share the same core values and mission of helping people to live a good life, right, as they define it, and to maximize their self-determination, their choice, and their control, really in all aspects of care. So just know that our intent is not to endorse any one single model. In fact, doing that would be antithetical to what we're talking about, because doing this well means kind of fiddling with a model instead of getting hung up on something like fidelity. So what we're going to do is just try to make sure that you're aware of the rich and diverse tools that are available out there to support different person-centered practices, with a specific focus today on those tools
that really support person-centered crisis planning. So next slide. So our job is really to build your toolbox, and your job is to partner with each person and family to then choose kind of the tools and strategies that feel like the best fit for them, right, given their unique needs and preferences. So we'll share some useful tips and resources along the way, but in 90 minutes, we can't possibly do an exhaustive review of that. So throughout the presentation, we'll be kind of sharing some key resources, including a lot of hyperlinks that will drop in the chat and that will be included in the slides, which will be distributed after this training to all of you, along with a recording to today's presentation. So I just want to really start with your very own sort of homegrown local resource, your North Carolina crisis planning template. Anita, if you can drop the link to that into the chat box so it's forefront for everyone. So in addition to the 3-page Excel form that constitutes the crisis plan itself, the spreadsheet template also includes a really nice training elements instructions tab on the front end. And we just want to call your attention to that because it offers, guidance around essential values, some really nice kind of step-by-step pointers around each part of the crisis plan, including detailed instruction around the completion of pages 1 and 2, which, as Robin was mentioning, those are the pages that may be new to some of you with the expanded requirement. So just a couple of things to note. You'll probably notice as you complete the 3-page plan that there's several places where you get data entered in that may exist elsewhere in the record outside the crisis plan, independent of the crisis plan. So for example, on page 1, you're prompted to enter, medication information. And this raises an important issue about consistency of information across the crisis plan and other parts of the documentation. Because just like the PCP, the larger person-centered plan, the crisis plan really should be treated as a living document. So it's important to have procedures to keep the data timely and accurate. And if you're going to be updating it in one place, to update it and align it in other places as well. And this is especially important around a person's use of medications. So a suggestion would be, for example, you can enter into the crisis plan your understanding of the current medications, but just add a note that says, for the most current and accurate medications, please refer to the medication administration record or the doctor's most recent note. And then one other thing to call your attention to on page 2 is the need to provide contact information for all the individuals who have to be informed in the event of a crisis, and indicating the necessary releases are in place, because this facilitates the meaningful activation of the plan, when others might need to step in and offer assistance. And they can't do that if we can't reach out to them or don't have permission to do so. So the best laid plans really don't mean much if we can't act on them when needed. So all that to say, we're going to be touching on a variety of additional tips in the training elements. But when in doubt, I would just encourage all of you, refer back to that front tab in the training elements, because there's some really nice tips in there. All right, next slide, please. So in addition to that homegrown resource that you have access to, I just want to, on the national stage, refer you all to a document called the 5 Competency Domains for Staff Who Facilitate Person-Centered Planning. That was produced by an organization called the National Center for Advancing Person-Centered Practices and Systems. And Amy and Leigh Ann and I have done quite a bit of work with them. And a few years ago, we put together this manuscript around competency domains. And the reason that I'm pulling it together for you is that Domain C in particular focuses explicitly on the topic of today's training, right? It's on maximizing rights, choice, and control in all aspects of service delivery, including in the process of collaborative crisis planning. So the nice thing about this resource is that at the back, there's an appendix, and for each domain, there's an actual list of a variety of different person-centered planning tools, worksheets, exercises that you can use to sort of enhance your skills and your practice in that particular competency domain. And this one in particular has a wide variety of tools, and they're all hyperlinked and they're publicly available. And you're going to be hearing a little bit more about a few of them later in today's presentation. All right, next slide. So there's lots of different things that can complicate crisis planning. We're going to talk about those in a minute, but having oriented you to the basics of the template and some key resources, I first want to take a step back and talk about why these plans and these planning tools are so important. So while this may at first seem obvious, it's actually not uncommon for practitioners and other supporters to struggle with the application of person-centered principles during increasingly intense situations. And even people who ascribe theoretically to person-centered care sometimes abandon that mindset when they're navigating these really difficult situations, especially if they don't have clear, meaningful, individualized crisis plans. Because in the absence of those kinds of plans, unfortunately, there's a tendency for us to jump to more involuntary or restrictive solutions without first kind of fully optimizing all the person-centered tools in our toolbox. And when that happens, it's a very serious issue because people experience involuntary and restrictive interventions as intrusive, disrespectful, and honestly, even traumatizing. So, when things go awry in this way, it's important to kind of keep our sense of urgency around this, that really can do irreparable harm to a person or a family, harm to the therapeutic relationship and ongoing engagement in care. So it's important to just start with the understanding that person-centered strategies are needed at all times across the continuum, but I would say they're arguably most important at a time of crisis. So now we can go to the next slide and talk a little bit about some of the dynamics which complicate this. So there's lots of reasons why we struggle with maintaining a person-centered stance at moments of crisis. It's no secret that service systems and those of us who work within them are historically risk averse. It's true not only for practitioners and administrators, but also other natural supporters who care about the person, right? Including family members. So I just want to acknowledge that this desire to sort of step in and protect, which sometimes leads to overprotecting, it almost always comes from a really good place, right? And it stems from the fact that supporters have lived through very real and scary and honestly traumatizing experiences where they've seen someone that they care about actually suffer. So it needs to be said, the stakes are high. There's very real fear when you're in that space. But while we all have good intent in these moments, the intent is not the same as the impact. So we just need to be conscious of the harm that can be done when we step in perhaps prematurely with interventions that inadvertently silence a person's voice. And I also I want to acknowledge here that I understand as a mom how really hard this is. And even though I'm one of your presenters today, I struggle in my own personal life at times when my mama bear instinct kicks in and I want to step in and I want to take control of a situation because I'm afraid. I'm afraid about what's going to happen, afraid about our daughter's future, afraid about safety. But I've learned from some really pretty great person-centered practitioners in our orbit that fear really can be mitigated with a clear and shared understanding of the things you should and shouldn't do in a crisis to support someone that you care about. Crisis planning is also complicated when there's no kind of clear definition or shared understanding of what constitutes a crisis. Everybody's degree of being able to navigate sticky situations kind of varies widely, and oftentimes what makes us uncomfortable or what we might define as a crisis does not in fact fit with how a person is experiencing things. So this comes up pretty frequently in the context of self-harm or suicide. So differences of perspective also come up around what we sort of see as supporters or perceive to be as, not in someone's best interests or as being kind of inappropriate or maladaptive. And Leigh Ann's going to talk a little bit more about that. But the important thing to remember is that we have to take time to dialogue with the person and the family and arrive at some kind of shared understanding so that we can manage the situation successfully together. And then finally, obviously, there's very real concerns around liability because no one wants to be the one, right, who doesn't intervene. And then there's a serious, incident around that. There's very real consequences for everyone involved. So that to me just suggests the importance of the larger systems approach to sort of reflect on and revise our risk management policy and procedures so that we feel confident we're both honoring self-determination to the maximum extent possible, but also building in strategies to increase safety. And finally, consistent with what we're doing here today, we just see that there's a very real need for staff training and tools in the field around person-centered crisis planning. So we're going to be taking a look at those throughout the day. Let me just go to the next slide and share a little bit about benefits of crisis plans. I just want to be sure to emphasize the importance of the P in the title of your template. It's a crisis prevention and intervention plan. Amy, I think, is going to talk to this a little bit more, but it's critical to take a proactive stance and sort of a staged approach when we're thinking about this topic, because yes, we want to increase safety, and yes, we want to reduce harm. We want to mitigate the consequences involved when people experience a crisis, because those are very complicated and real, and they include everything from emotional to practical to interpersonal consequences, loss of self-esteem, loss of jobs, housing, relationships. So of course we want to avoid those consequences. So we want to be thinking about using this plan proactively to avoid the crisis in the first place. So while we tend to focus, and I think it's really critical, on all of these different human costs associated with the experience of crisis, I also want to point out that there can be fiscal savings potentially if we're doing really quality person-centered crisis planning. And there's data to actually support this, that it can reduce high intensity, high cost services around emergency room visits, hospitalization. So you see not only an impact in people's lives, but also an impact on the fiscal bottom line. So having said a bit about the benefits from this, we're going to transition over to some core values that are going to help you actually practice person-centered, quality person-centered crisis planning. So again, I just refer you back to the guidance that offered in the training elements tab of your crisis planning template. There's a wide range of core values there that were developed collaboratively by a really diverse group of stakeholders, including individuals and families with lived experience. But just a few examples to highlight today include things like shared responsibility and how a shared responsibility around the creation of the plan might lead to really a blending of voice within the planning document itself. So it should always be viewed as a partnership-based process and an intervention unto itself, and not just a form to satisfy a requirement in the medical record. And it honors the family's wisdom, the individual's wisdom, but it also makes space for your professional contributions. So the implications of that, you'll see later when we take a closer look at page 3, is that the prompts are written in a way to actually solicit sort of first person, I statements, quotes from the individual. And someone like Roma, who we're going to take a look at in a bit, she may be very, eloquent, articulate, and may be able to express herself in a way that you can get to a meaningful and actionable crisis plan. But the truth is, many people are not going to have that same level of comfort or ability to do that. So the plan may need to be written in more of a provider voice or a hybrid, of the two, which you're going to see a little bit more in the example of Fred that we're going to share. So the general rule I would say here is if a person's able to articulate things in their crisis plan, by all means, go for it and include as many quotes as you can. But in cases where they can't, or they're uncomfortable doing that, or they're not using verbal language to communicate, then in those cases, we still have an obligation to capture exactly what we know about what works and doesn't for the person based on all sources of diverse data, which include your own observations. As Leigh Ann's going to talk about, finding people who love the person to give you some observations. Another core value is the need to kind of think about the plan as a living document. While we do a pretty good job of satisfying our minimum requirements, Oftentimes, we really struggle to update the plan accordingly when there's been a change in the person's preferences or their situation. And also, revisiting the plan and considering important modifications after a crisis has been resolved. So asking key questions about what did we learn in activating this plan? What worked well, what didn't, what do we have to rethink and potentially modify so it's more effective in the future? So there's lots more that we could say about core values, but again, please refer to the nice tips in the training tab and also some of the SAMHSA resources that are embedded. So let me go on to the next slide, Ingrid. Say a little bit about access and sharing the plan when needed before I turn it over to, I think, Leigh Ann. So in order for the plan to be effective, it's got to be accessible to the people who need it at the moment they need it. But this raises really important questions about who should have access. So we would suggest from a best practice perspective that first and foremost, the plan should be shared and prioritized to be shared with whoever the person elects to share it with, okay? But having said that, it's also perfectly okay and encouraged to offer suggestions if a person that you're working with maybe omits someone that you think is kind of a key need to know individual or organization. So that could include certain providers, call centers, warm lines, mobile crisis, even local ERs and law enforcement, because these people and institutions are in a position to better support and make referrals at a time of crisis. And they can increase the overall responsiveness of the crisis service system, right? How we're managing crises. And that's true in the community, right? When you think about law enforcement response, oftentimes we see headlines with very tragic outcomes when they're intervening, supporting a person who's really struggling, a person with a disability. And they're very often following established protocols, but established protocols oftentimes don't map on well to the unique needs of people with disabilities. So if you have an autistic person who has severe sensory integration distress and you're approaching and there are flashing lights and megaphones, offering instructions, that's very likely going to escalate the situation. And the same is really true in emergency or hospital-based settings that, we really need, clarity in our instructions about what's helpful or not at that moment. I can remember 25 years ago, before I knew what a psychiatric advance directive was or an advanced crisis plan, sitting for the better part of 2 days in an emergency room while someone I was supporting was waiting for a bed. They didn't have one in the emergency room. Say they were restrained to a hospital bed in a hallway. And I just remember feeling myself personally traumatized going throughout that, and also pretty helpless, like not knowing what I could do differently, right? And just keeping in mind, if I'm feeling traumatized, what is it like for this man when I go home at the end of the night, right? What could I do differently next time? Could I have brought you a sandwich? Could I have brought you puzzles to do? Is there someone I needed to call or something I needed to take care of at home? So they're critically useful in both community settings, hospital settings. And in terms of making sure that people have them, again, just a reminder to be conscious of securing the necessary releases of information. Be careful that we're also honoring people's expectations and preferences if they give us explicit instructions for someone they do not want that plan shared with, because there's a variety of valid reasons why that might be the case that we need to be conscious of honoring, even though we're encouraging and educating around the benefits of sharing to kind of coordinate efforts, okay? Last thing I would say is that, we want to facilitate access, to the document, either by sharing for the person or just saying, listen, if you want to share this yourself, we'll make copies here. So you can just make sure that you can deliver them to the people that you choose, or I can make sure I distribute them by email. So next slide here. I think this may be, this is Leigh Ann's cue, and I'm going to pass it over to her to tackle some of our other topics for the day.
Great. Thanks, Janis. And I'm just kind of paying attention to time. So I've got, looks like about 12 or 13 minutes. So
I think you can go to 15. We have a little wiggle room at the back end. I know it was a couple over. Yep.
Okay. All right, so I'm going to keep my timer going just so that I don't get too far out of line here. Hi, everybody. I'm Leigh Ann Kingsbury. For anybody who needs visual accessibility, I am a white woman. I am wearing red glasses. I've got dark brown hair, brown and gray these days. I have on a white shirt, and I'm sitting in my home office. There's a bookshelf over my right shoulder, and some files and such over my left shoulder. And my pronouns are she, her, and hers. So I have the absolute joy and privilege of having spent the last 35 years in North Carolina, engaged in person-centered practices. Early days of the Thomas S. lawsuit back in the 90s, ran a provider agency serving people who were part of that class. It was a class of people, a designated class of people who had intellectual disability and or were treated as such, but were inappropriately housed in state psychiatric facilities. I've spent most of my career with people who carry a label of challenging behavior and or people who have really complex healthcare. So I tend to say that I've had one foot in the healthcare space and one foot in the disability space for most of my career. I've spent most of my career consulting, and or the most recent part of my career consulting. I've run a couple provider agencies. So, you know, Janis, I was listening to you say, you sort of that sense of being a parent and the worry and concern that a parent has. And I wear that hat from a provider standpoint when I think about the balance of risk that we have to take, and what that feels like as a provider and a provider director to go to bed at night and think, you know, there are people that I have responsibility for from a system standpoint that I worry about and I care about. So I really appreciate that sense of you know, worry and angst. So in the spirit of time, I'm going to move us ahead. So thank you, Ingrid. So, you know, I'm really thinking about this from kind of, because of the time that we have, I'm really thinking about this kind of from some overarching places. So in the crisis plan on page 3, or I'm sorry, not page 3, in the crisis plan, the first tab, training and instructional essential elements, I think, or instructional elements, gives you very clear guidance, step by step by step. It is just a spectacular document if you want sort of something to check yourself against. So I'm not going to repeat those details. This is kind of the lens I want you to put on this. No matter what, no matter where we are in our engagement, we start with a presumption of competence. We recognize in that presumption that there are times where people are really struggling and maybe fully incapable. From a legal sense, we'd call that incapacitated or not having capacity at that moment to make a decision that will serve them well or not hurt them. But we start from that place of a presumption of competence. And we always engage with shared responsibility and decision making. You know, I'm certain you all know this. The worst thing we can do when somebody is in crisis is try to force them to do something they don't want to do. And though there are times when we're in that position and we work really hard, for example, if somebody does need to be hospitalized, you know, we're starting in a place where we're saying, what would it look like if you checked yourself in versus if we had to make that decision for you? But it's sort of the thread that runs all the way through this, is this notion of a presumption of competence and shared authority and decision making. We want to be really clear about what other tools exist. The crisis plan is part of, or may be part of, if you will, sort of a suite of decision tools that may exist in somebody's life. So you might have the crisis prevention plan, you might have somebody might have a healthcare power of attorney. Somebody might have a supported decision-making agreement. We'll talk a little bit about that. There might be an authorized representative agreement where somebody just has given permission to somebody else in their life, you know, for example, to access their homeowners association so that they can make sure their homeowners dues are paid or something like that. So you want to be clear about, are there other tools that also exist? What those tools tell us, one also they are preventative in nature, but they also give us some information and some insight into who else is in the person's life, and who else have they relied on and counted on to help them out. We want to be really clear about what the person expects from us. You know, Janis, you said this, and we've talked a lot about this as we've been planning this content, that what sometimes the system feels like is a crisis, or a family feels like is a crisis, or a provider feels is a crisis. The person may not feel that way at all, and that requires then some conversation with the person and anybody else who's supporting them around, what's the expectation here? What do you expect? When do you expect us to engage? And I will just really want to piggyback on, and who do you not want us to engage? That is so critical to understand. Who should we not be involving in this process? We do want to have, from a system standpoint, again, if you sort of think about a provision of services, we want to have a handle on who's the point person during all of this. Is it a spouse? Is it an adult child? Is it a provider? Is it a sibling? Like, who is it that's kind of the point person that we can kind of keep that communication going with? And if somebody's hospitalized, who is visiting? That might sound like a really simple question, but I can tell you, 30 years ago, we weren't actually permitted to visit people we provided services with in some hospitalization situations. We help somebody check themselves in to a psychiatric facility and then are told you can't spend time with them. We can't, and we are the only support they have. How does that person feel? There's that trauma right there about feeling like people that I rely on aren't here. People I rely on can't even come see me. So while that has changed over time, there's a reason for it. That's an important question, really important question to answer. Can we go to the next slide? Thanks. So these are some of the questions that we get a lot, and I'm going to focus a little bit more today on serving people who have an IDD diagnosis, though this is broadly applicable, but that's sort of my lens for today. So usually big questions around, how do you do this work with people who don't use speech for communication? Those are folks who often get the label of nonverbal, and we're going to talk a little bit about speech in just a moment. How do we do this with folks who have a history of challenging behavior? And what do we do? How do we do this with folks when we really are it? When we meet those folks who are disconnected from other unpaid supports in their lives, whether that's, their family or their friends or their neighbors. Maybe they've lived in a facility for a really long time and are just disconnected. Maybe they've done some things that have been really hurtful to other people, and so they're disconnected. But how do we think about prevention and planning with folks that may be in that situation? We can keep going to the next slide, please. Thanks. So a couple of things I want you just to think about around this idea of communicating with people or supporting people who don't use words or speech to communicate. Speech is a motor skill, language is cognitive. And so when we say that person doesn't use language to communicate, or they don't use speech to communicate, or they don't use words to talk, what we're really saying is they don't have, to the best of our knowledge, we might know this, we might not, but they don't have the motor skills for speech. It doesn't mean that language isn't translating in their head and that they aren't paying full attention to what we are saying. So we want to be clear that it's about speech when somebody is carrying a label of nonverbal. I'm again reiterating some things I'm sure that not talking, not using speech does not equate to not understanding. Lots and lots of folks out there, particularly folks who have a neurodivergent label, who don't use speech as their primary means of communication, but are fully on board with what we're saying, what they're thinking about, and our challenge then is to figure out how to get that communication going in a way that we can understand it. Presume competence, ask permission. We want to engage with, most of us want to engage with somebody else in a way that works for us. And if somebody just starts asking us questions, if somebody just starts making assumptions about us without a permission to have a conversation, without permission to probe a little bit and explore, imagine how uncomfortable that feels. So whenever we're talking about or talking with somebody who doesn't use speech for communication, we want to be really clear that we have permission to talk with them and then to talk with whomever it is that's going to share the information with us. We're going to have to identify that person that can share information, and we want permission of the person to do that. Basics. I mean, some of this is just really basic, but we don't often think about it. When we're in that space of supporting somebody. Doesn't matter whether the person uses speech or not, we engage with the person first. They are the person receiving services. That's who we talk to first, right? Use their name often. Make sure that you're making eye contact and you are getting that person's attention, and that they're following along with you. As much as you may know that, you may not be able to tell that. Make sure the person knows that you're going to talk to, whoever it is that's with them, that's sitting with them, to help provide that communication and that information. Ask permission to talk to that person. Make sure that person knows that you're going to be talking to that person and asking them for information and answers if the person isn't able to give you those answers. Take your time and allow time for the person to process. I used to provide services for a guy that always took a good solid minute to answer a question. And you could see him kind of working the question through his head and thinking about, what is it she's asking me? What do I need what's the answer here? But people would then say, they'd ask him the question again and again and again. And we had to realize that he needed a good minute or so to process. And then this last piece, when somebody doesn't use speech for communication, we are reliant on finding other people who know and love and care about that person. And simply knowing the person, oh yeah, I was a job coach for them, for 3 months. That probably isn't enough. It might be enough depending on what that relationship was like, but you're really looking for people who care about this person. Next slide, please. So people who have a label of challenging behavior. Again, I'm going to start with presumed competence, but also I'm going to add here assumed trauma. Assumed trauma, I think, is a global assumption anyway. When we're serving people with disabilities, we know that more than 90% of people with disabilities have experienced some kind of significant trauma in their life. So I would add that really to any, sort of ground rule, if you will, or any value. I would also say for people who have a label of challenging behavior, part of what we have to do is just stop. Sometimes we just have to stop talking, stop moving, and just watch and listen. You have to believe that behavior is communication. Behavior is communication. Behavior is always communication. The challenge for us sometimes is figuring out what the heck is the person trying to tell me. And anytime we're serving somebody who comes to us with that label or has been introduced to us with a label of challenging behavior, we have to both look at the depth and breadth of that person's life, take a real longitudinal approach. What is going on? What has gone on? Not just, here forward or here backwards, but sort of look at all of that person's life. And what are the ways that we can give control and power back? Right? How can we share that authority and get in that position where we stop, we just stand still, we sit still, we stop, and we give authority and control back to that person. Next slide, please. So if you've been through person-centered thinking training, you've seen this slide. I'm not going to spend a lot of time on it, but I do want you just to think about this notion of power over and power with. And I want you to pay attention to where do people spend their time? Are people spending time in places that feel toxic to them? Doesn't matter whether we think it's toxic or not. Places that feel toxic to them. Are they places where they sort of tolerate being there? Whether this is where they live, where they spend their days, where they go to work, doesn't matter what the environment is. It's just that's a place the person is spending time. We really are looking for people to spend time in places that are supportive. And some people have spent time in such a long time in toxic places and barely tolerated that we really need clinical intervention. And we ought to be looking at healing spaces in addition to supported spaces. So when somebody is presented again to you as somebody with challenging behavior, pay really close attention to the environment that they're in, and really give credence to, it may not look toxic to us, but it may be to them. Next slide, please. And then the last piece of this, supporting people when you just can't get information, when information is really sparse. The first thing I'm going to say to you is do not underestimate the influence and impact you may have. For people who don't have non-paid supports in their lives. They are estranged or disconnected or just don't have other family. You know, I'm also a gerontologist. I spend a lot of time in older adult services. I spend a lot of time with people who don't have family any longer. Don't underestimate, you know, your connection to that person may really, really matter to them. You may be one of the only people that's actually taken the time to sit down and listen and really pay attention, right? Recognize that if the person has a history of hurting others, whatever that looks like, however that's perceived by others, recognize the lens through which you're going to get information. When we don't like someone, when someone gets on our nerves, when someone has hurt us, it's very hard to identify gifts and strengths and talents. We tend to lead with disdain and snark and not empathy and compassion because we don't feel that for that person. And so we have to recognize that when we're seeking information for somebody who has a history of hurting others, that you know, that the information we're getting may very well come through that lens of disdain, dislike, and snarkiness, and not compassion and empathy. And that's just important to know when you think about, you know, finding people that actually like somebody and care about somebody and can help you kind of fill in those gaps that you may not have because information is so sparse for that person. Next slide, please. All right, so a couple last things here to know. You know, when you were thinking about supporting people, particularly people who need a lot of support, if the recommendation is that they really need structure around that support, one of the ways to do that is supported decision-making. And supported decision-making is really gained momentum across the country. It's a legally recognized decision support process. It essentially is a process where the person says, here are the 3 people that I want to have help me. I want, you know, my sister to help me with financial decisions. I want my dad to help me with healthcare decisions. And I want my brother to help me with you know, work decisions. The person decides who those supporters are, and that information is then formalized, and that I'd say that loosely, but it is formalized in a supported decision-making agreement. North Carolina law does not spell out the requirements for an agreement. Ingrid, or I'm sorry, Anita, I forget who's doing links. We have a link for the National Resource Center for Supported Decision-Making. If we could put that in the chat, that would be great. Typically, a supported decision-making agreement has at minimum the name of obviously the name of the person, the name of the supporter, the role that supporter is going to provide, the start and end date of the agreement. It doesn't have to, not all of them have end dates. Sometimes they just have kind of a check-in date. And it is typically witnessed or notarized. The thing to really know is that remember that supporters are not decision makers. They are supporters. This is about walking kind of in tandem with the person and helping somebody make decisions when they ask for support or when they've said to you, if I'm doing this, I want you to help me figure out the decision I need to make. And specific to North Carolina, supported decision-making meets our SB 615 law around guardianship, which says if guardianship is being considered for somebody, we have to demonstrate that we have tried a lesser restrictive option first, and supported decision-making meets that law, meets that rule. All right, I think there's 2 more slides here. Next slide, please. Yeah. The other thing, you know, I think I mentioned this earlier, just make sure that you are capturing what other decision tools exist for the person. They may be, and you want to make sure that you're just acknowledging these and capturing these when you're talking about crisis prevention and intervention. There might be a behavior plan. There may be a suicide prevention and intervention plan. There might be a RAP plan. Amy's going to talk about that. Just make sure that you're capturing that so we know, the system knows, anybody else who's providing supports knows what other decision tools exist for the person. And last slide, please, for me, I believe. Thank you. Yeah. So we're going to get you all these links at the end of the webinar today, but there are lots of other tools available out there for you. So specifically things that are helpful in crisis communication charts are helpful, debriefing and using a 4+1 tool, looking at longer term learning with a learning log, the matching tool, we really figure out are the people who support this person, kind of the right people in terms of personality and skills. Sometimes just saying to the person, let's think through a if I could, I would kind of scenario. Charting the life course inclusion, all of these are great resources and tools. Again, Janis said this, we are not specifying a specific framework. The theme that will run through all of these is this theme of self-determination, choice, control, that the person is the expert of their life. The last two on here are the National Resource Center on Psychiatric Advanced Directives and RAP planning. That's our segue for me to hand off to Amy, who's going to talk much more in depth about those. Amy?
It would not be a webinar if I did not forget to take myself off mute. So my name is Amy Pierce, and I am an individual with lived experience, and where I come from and the work that I do really stems from that. It stems from my journey in the mental health system and through a space where many persons at one time told me the things I would never be able to do, like live on my own, go to college, all of these things because of the diagnosis that I carried. And through that, I was able to find a space because I had persons who surrounded me and believing that I could step into working back at the same state hospital I was hospitalized at for almost a year. And it's there that I started the first peer support program in the state hospital system. And that work has really, that I didn't even know was work or even was something that was anything that you could do, has been something that I have been doing for now like 24 years. I've worked in local community services. I've worked for myself where I've traveled the world supporting organizations in implementing peer services and other recovery-oriented programs. I am a RAP, an advanced level RAP facilitator. And I say that because I just want to acknowledge, like, that's where a lot of my, the bias that I have for my own self and what's worked. And so I will be sharing from that. And just like they've said, there's so many different ways to support individuals in connecting with what works for them and what speaks for them. And I love person-centered planning. It's actually the thing that had me leave where I was working at the state hospital for 12 years and transition into the community services because I heard about this conversation. I was like, that's incredible. Like that. And I'll tell you why. For me, one of the pieces is that each human being, like, we have a voice, and a lot of what persons do as providers trying to figure out and find ways for that voice to be heard. And that includes spending time and taking that time for the individual to find out, like, what it is that they need, what it looks like. And you can go to the next slide. One of the things for me that was really integral in that process was actually going through what we call the Study of Mental Health Recovery, including the RAP, including Wellness Recovery Action Plan, which holds the crisis plan and the post-crisis planning. You can go to the next piece. And you're going to have some slides, and I'm not really going to talk about them, but you'll have those as kind of examples. This right here is the initial structure of what Wellness Recovery Action Plan, when we look at the evidence-based process, looks like. And if you'll go to the next page, I'll just talk from there if that works with y'all. And this is one of the things with RAP, it's ever growing, it's ever shifting as we learn new language, as we create this space that's open for anything. And Advocates for Human Potential has released this as the new general structure of Wellness Recovery Action Crisis Plan. And all of that to say is, for me in my journey, one of the things for many years that I think I was really challenged with is that I knew how to be a really great mental patient. When I say that, I knew how to get into the spaces where I would be safe, where others would be able to take care of me. I didn't know how to actually live. I didn't know how to live in the community where there were places where I didn't always trust myself or my decisions or the actions that I had done in the past. And, for me, looking at rap and going through this process created a space where I started to learn about myself. I started to learn about what I liked. I started to learn about the stressors, but not just learn, there were actions I put into place. Actions if I had early warning signs, there was actions I put into place. Actions if I got to the space of what is deemed when things are breaking down. Whereas for some people that might actually look like a crisis, but like, what does that look like for me? Because when it's deemed when things are breaking down, that means that I still can do the shift. I can still hear myself even in the midst of chaos. And I say that because I think that's one of the things that is really important when we look at crisis planning and the crisis plan is finding different ways to hear the individual, as they've said, and also what's deemed a crisis by that person. Because for many, one of the things that's in my when things are breaking down section is that I actually have in there non-suicidal self-injury. While it's something I've not utilized in many years, it's something that I know is a place where it's a wellness tool, or it's a tool that I use in the past to navigate where I'm at. And I know that if I hear that, or if I feel that from having these experiences, I have action plans in place that I can enact, right? Which includes calling someone, going to a hotel, a safe space. The key is that I can enact. When I get to the place of crisis plan, I'm saying and I'm telling people that I need you to take over and what that looks like. And I spent a number of months really exploring this because oftentimes I was scared to even think about crisis. I was scared to go in that hole. And going through the conversations around rap and this, it helped me really find and look for myself that, a crisis wasn't something to be feared, and it's something that I could plan for so that my voice could be heard in the places and spaces where it never was before. So that my voice could be heard in places where persons may have placed or given me medications that actually would have a really negative impact on me. But if they didn't have my chart or didn't know who I was, they wouldn't know that. And so I had to look at what could other people see, right? In that part two, signs that others need to follow this plan. If you're seeing that I'm not taking a shower for 5 days, this plan gets enacted. If you're seeing that I'm eating frozen food for 3 days, this plan gets enacted. If you see that I actually am saying and talking around that I have a very specific plan to end my life, this plan gets enacted. Because it's what others can see. And I learned a lot of what those were from talking to my support system. What have they seen in the past, right? And if those signs show up, it's then what do I want people to do? What do I need people to do, right? What are the things in my life that are going to support me so that hopefully when I come out of this space of crisis, I've not lost my home. I've not lost my job. I don't have 13 warrants for my arrest, which I came out of the hospital. That was probably the most at one time because I had written a lot of hot checks, because one of the things that shows up for me when I'm in the place of crisis is that I will spend lots of money without any care because I know that I'm not going to be here in this world anymore. Right? So what structures can I put into place where I don't have to come out of a crisis and be navigating that? And so in this exploration, and I will tell you that a number of years ago, I actually had to enact my crisis plan. And in that, I had a person who is deemed the person who, if this plan is enacted, that they have all the passwords to my accounts, they have all the information on all of my bills. And because they're a numbers person, they take over taking care of that. They change my account numbers, they change everything. And there's a limited amount of money that I'm given during that period of time because I say so, which is I said so, which is very empowering, even in the space of that my voice typically has not been heard. I have supporters who come and stay with me, who know that if this happens, that I have certain persons in my life who will come and stay and are connected with my doctor. And there's a plan with my doctor where there's an emergency medication that they will give me oftentimes that supports me to kind of like navigate where I'm at. They have instructions about making my house safe, and if they're not able to, about staying in a hotel room. And there's money in my safe for should that happen. Because for me, I would really don't want to end up in the place of being in a hospital again. And having this enacted and in place allowed me to actually go through a space that I automatically would have been placed in the place of involuntary committed, to a space where I was able to navigate safely in my own home. I was able to navigate safely where persons knew the foods that really worked for me and what I needed with those foods if I was in this specific place and this specific action was going on. And that included they had to microwave things for a certain amount of minutes because then I would eat it, right? And I didn't have to worry about certain persons coming in and telling people all these things about me when they really weren't involved in my care just because they were a family member. And I love them to death. They just don't understand when I'm in that space. And that's the whole place we've been talking about, like who's involved and who may not be involved and the why. But most importantly is what does it look like when this plan should become inactivated? Right? Because I'm saying that if you start seeing that I'm able to take a shower every 3 days, or I'm actively looking at taking a shower or asking for support, that there are a number of items that state that when you see this happening, this is the space where I'm going to start taking over my care. Doesn't mean that I may not need your support. It just means that I may need your support to look like this. And there's a list of what those things look like. And that list and includes persons who may mow my yard, because that's not something, it's important that it's done, but it's not something I have to spend the energy of. Somebody may include a list of persons who will support me as I take over, maybe cooking for the first time. But just in this really short period of time, the thing I want to say about being able to craft and create a crisis plan that works, that actually lives out in the world, that shifts and changes I do, that I'm actively involved in, has allowed me to feel safe enough to take chances in my life. And chances include going back to work. And chances include owning my own business and traveling the world. Because without that structure, I was terrified. And now I know that I have a place where my voice can be heard. I have structures in place should something happen. I have all these different things that get activated. But I also know that I can go through the place of crisis, and it's not a dirty word. And I say that kind of funny, but it usually, like, it was like the thing to be feared. And I don't have to fear it anymore because I can learn from it. And each time I have experienced something, I've learned that places where I needed a shift, including like sharing other parts of my RAP plan, because I had a friend who was there one of these times, and she came in the house and all of my cabinet doors were open. Well, that's an early warning sign for me, right? But I didn't notice it. I didn't catch it. And, sometimes I say it takes a village for me to be here in this world and to do the things that I get to do, and how great that there's a village that surrounds me that I get to choose. But most importantly, how great is it that in the place for many years my voice wasn't heard, that I have a belief that it will be heard. Because when it's heard, that's where I get to heal fastest and in the way that I know works for me. And I just love the fact that y'all are exploring this and looking at this and what you have included in the plan. And, you know, finding different ways for me to be able to find that information. And, you know, it looked different at different times. And I still have a crisis plan today that people have. But I don't just have it around my mental health. I have it with my physical health. I've created crisis plans around moving. I've created crisis plans while my mom was going through the dying process. And that crisis that inactivated that plan was when she passed away. So just kind of a thing that RAP has kind of brought to me in the structure of that crisis plan. And I just thank y'all. I think that was about the time, Janice.
That
I'll go
is
fast.
my cue. Amy, I just want to say out loud, and I added in chat, just how much I appreciate you and how thankful I am that our paths crossed so many years ago. You know, your story just so powerfully illustrates, you know, how you can still hang on to voice and choice, even in the most intense moments.
And you
And
can
in
still
fact, yeah,
be a person who hears things and sees things that others don't and live a really incredible life.
yeah. Absolutely. There's lots of appreciation and love coming into the chat box, so check it out. If we can go ahead to the next slide, we're going to very, very briefly just touch on a couple of examples. Keep going. One more. One more. Okay, so we're going to wrap this up by looking at a few examples. So on this slide, there are just kind of a couple of key reflections. How do you know what a good crisis plan looks like, right? You know, and the basic thing you want to keep in mind, as you can see from what we've been sharing and as Amy illustrated in sharing some aspects of her own crisis plan, is that you want it to be written in a way that it's almost like a prescription in the sense that, I mean, it's collaboratively developed. It's not directive, but it's written in a way that a person who doesn't even know Amy or someone else can actually pick it up and do something meaningful to support them in a way that's consistent with their preferences. So if you can go to the next slide, we're just going to illustrate this. Hopefully many of you, go ahead to the next slide. This is just a snapshot of your page 3 of your crisis plan, which I would say is kind of the meat of the crisis plan, where you're able to really enter in a lot of that individualized information. But many of you may remember the story of Roma, who we introduced in the year 1 training. Roma was someone who was a loving mom of 2 teenagers. You know, she had lots of strengths and incredible resilience. She had a supportive cousin, creativity, work history, and many of those things had helped her to be resilient and to survive a really pretty horrific experience of multiple traumatic experiences, including being abused by her biological father and having a child out of that relationship. So Roma's teenager as a result of that abuse. So Roma struggled throughout the years with really complex mental health issues, fell into using substances when she was in really acute distress, has had some experiences being, unhoused at different points, in and out of incarceration. And at the time of the story, when Roma connects with the service organization, she had been released from a period of incarceration, was living with a cousin, but started to struggle with drinking again and was having really volatile arguments with her oldest teenage daughter. And then subsequently was asked to leave and ended up in a shelter, okay? So that's just a little bit about the backdrop of the story. If we can go to the next slide. Actually, one more, I think, just in the interest of time. Okay, so let's just take a quick look at like a couple snapshots of the crisis plan. Again, do not worry about reading the tiny font because you're going to get copies of these files. What I just want people to keep in mind that what you're seeing on the screen here is like not necessarily a reflection of a spontaneous soliloquy that comes from Roma, right? You know, she was in fact very articulate and able to express herself. But for many people, and even in the beginning with Roma, they may first offer up only a brief response with really limited details. So say, for example, Roma says, you know, the biggest sign that she's in trouble is when she starts drinking, but she doesn't elaborate. And that's where you do your job as a partner and you use your very best person-centered interviewing skills. And you ask the follow-up questions, right? The kinds of things Amy was talking about. How are your supporters going to know when you're really starting to struggle? What does that look like for you? Are you more social? Do you isolate? How do you act? Or what do you struggle with when you're drinking? And you see what that results in is, a lot more specific detail. I might start blowing off meetings or blowing off my shifts helping at the front desk at the shelter. And I'm really on edge. I'll be getting into it with people at the shelter and I might start yelling, okay? Same thing around her experience of acute trauma symptoms. Roma may initially just say, I get flooded by bad memories, but if you're following up on that, you want to get more detailed information. When that happens from you, how are we going to know so that we know how we can best help? And so Roma may tell you, I try to escape. I just stay away from everyone. I have a hard time taking care of myself. I may not sleep. I may stay in bed all day. I forget about my bills. I can't find the energy to take care of the basic stuff I need to, even things like taking a shower or changing my clothes. So again, just want to highlight there the importance of the collaboration around that. And let me make one more quick point on this next slide before I let Leigh Ann share a little bit about Fred. So on this next slide, just something that I actually even learned in the context of creating this sample plan for this training and this initiative. So remember I said you want it to be written almost like a prescription. Somebody can pick it up and run with it in a meaningful, helpful way. So originally when I had drafted this, I had embedded in there that Roma has a preference around using different mindfulness strategies that the therapist had been teaching her. And Justin asked me a really, really important question. And right, because this could look like many different things for many different people. So what does that mean exactly, right? And how do we need to kind of elaborate on that? So maybe for Roma, what that means is that, she's practicing gratitude. I'll sit quietly in the morning, make a mental list of things I'm grateful for. I've got so much anger about the past, but practicing that helps me let some of it go. Deep breathing is also helpful, but I really can't do it with my eyes closed. I get very anxious, right? So even just being conscious to further flesh out that details so it can be used in a meaningful way. And now I'm going to pass it to the next slide in Leigh Ann to briefly orient you to Fred. And again, we're just doing this to illustrate, and you're going to get copies of all of these.
Thanks, Janis. We chose Fred because Fred is somebody who doesn't generally use speech for communication. He signs a little bit, but much of his communication is really just knowing him well and kind of watching his actions. People describe him as funny, really kind, loves to help. He absolutely loves to be. This is a guy whose, love language would be, gifts of service, I think is one of those. He really wants to be helpful. Fred lives at home. And one of the challenges for Fred is his dad and his brother are commercial airline pilots. And so they don't go to work. They don't get up in the morning and go to work at 8 a.m. and come home at 5 p.m. They get up at whatever time and they disappear for 3 and 4 and 5 days at a time. And then they're home for 2 weeks. And Fred has a job where he gets up and he's supposed to be at work by about 7 in the morning. He works for a landscaping company. It's been there for several years, has great support, but he struggles sometimes when dad and his brother's name is Eric, when dad and Eric are gone. And he's sort of befuddled, I think, by, wait a minute, nobody else has to get up and go to work like this. Why do I have to do this? Usually he does okay, but there are times where he really struggles. And so when he's really, really struggling, what his mom says he'll argue, except that arguing, we tend to think of with language, he argues by doing things like, he'll refuse to pick up his dirty clothes if his mom asks him to, or he'll sign no a lot, or he'll sign dad or airplane a lot. But one of the things that we've learned about Fred is, when Fred's really, so let me pause for 1 second and say, broadly, the great thing about Fred's plan is people who know him and really love him have over the years said, what do we know works for him? Like, what have we figured out really works? How do we prevent as much as possible these just outbursts that he has where he seems really distressed? And if we aren't kind of clued into it and paying attention to it, Fred will do things like he'll be at work and he'll pick up a clay pot and he'll toss it. He'll throw things, he'll walk out the door. And what people have learned from that, if you think about it kind of from a harm reduction standpoint, what people have learned is that physicality, picking something up, pounding it, smashing it, stomping its feet, those are the things that actually work really well when Fred is anxious and worried. So if we go to the next slide, we'll just see a couple of pieces of his crisis plan. So when this is the first part of it, when he's feeling well, he's happy, he's funny, he's kind of silly, he likes to be goofy, he loves being helpful at home. He's also somebody who likes to be busy. He's not somebody who just likes to sit around and not do much. And that's important to know because his mom has discovered that when he's not sleeping well, it's one of the things that'll happen. He's really worried about his dad and his brother being gone and when are they going to come home. He won't sleep well. And if he isn't sleeping well for days on end, she will, he has a Klonopin prescription and she'll give him a small dose of Klonopin to help him sleep. There was a consideration of could he take that during the day when he's really anxious, and it makes him really drowsy. And even though Fred can't say to us, I don't want to take this medication because it makes me really drowsy. Like, he doesn't have the motor skills to say that sentence. People that know him and love him, and again, his mom and his dad have said, we're pretty sure that he would not want to feel loopy and drowsy all day long, knowing how much he likes to be busy. And so we don't use Klonopin during the day. You get a picture of some of the things that happens here, when he's really struggling. His sleep patterns change. Again, argues with his mom, just kind of doesn't want to get up and go to work on his own. And then he'll be antsy. He'll make a lot of sounds, he'll make a lot of noise, he'll pace around. And his supervisor at work will say, we can always tell when he's starting to struggle because typically I can ask him one time to do something and he'll go and do it. And if he's really starting to struggle, he's not going to follow through on those simple, well, not necessarily simple, but those tasks that typically for him have been easy to do. And then, now he can't do them. Next couple of pages, again, I'm not going to read through all of it, but if we go to the next slide, we'll see you've got more information here about, what helps and what other people can do. Again, for Fred, the two best things are, engage with him, talk to him about Dad and Eric, acknowledge that anxiety. If you've got a calendar, point out on the calendar when they're coming home. And then if you happen to be a runner, go for a run with him. If you think it would be fun to go outside and, smash some gravel, go outside and smash some gravel with him, because that actually works. It's very much sort of a harm reduction lens for Fred. That physicality makes a huge difference. He had a direct support professional once who was a CrossFit athlete. He loved nothing more than going and working out with her, flipping tires and climbing, and that real physicalness is the stuff that makes a difference for him. I'm going to stop there because we just don't have time, but you've got his full plan, or the full crisis plan for him also in the documents that you're going to get.
Thanks, Leigh Ann. Ingrid, if you do me a favor, go to the last slide so we can get our evaluation link and instructions up. I put a note in the chat that many of us have been trying to respond to questions as they came in, but please feel free to put additional ones here now. There's quite a bit of questions coming up around how to be managing tensions when a legal guardian does not have the same vision as the person that you're supporting, whether that's court-appointed independent guardian, or whether that's adult parent of minors, et cetera. One thing I just want to say, in addition to Leigh Ann put some great feedback and resources in the chat, is that this is a question that has come up frequently in the past, and we are actually planning in this upcoming year to do a webinar dedicated specifically to this topic. and really what the best practices are. Anything else from our team of co-hosts here? Is there anything that you all can see that we missed in the chat or didn't get to, or anything that anyone else needs to add?
Janis, I'm just going to say, relative to the guardian question, this is not going to answer really the question, because it is really a tough conversation sometimes when you have a guardian who is sort of superimposing their interests on the person. But the National Guardianship Association, which is guardianship.org, we've put that in the chat and it's in your resources, has very, very clear standards of practice and position statements. So just from a sort of learning yourself about what the expectations are of a guardian, that's a really, really good resource.
Yep.
And North Carolina's Rethinking Guardianship, which is rethinkingguardianship.org, I think. We also put that in chat, is also a really good resource and has some additional resources that you can access.
Yeah. And I would just piggyback off of that, because, you know, we have these standards and expectations, and they're clearly written into law and best practice guidelines, but oftentimes they're still not followed. And you find yourself really in that sort of go-between position. And I would just say, both as a professional, but also as a mom, that it's important, again, to remember when someone is sort of stepping in with restrictions, perhaps prematurely, that component I was talking about in my, earlier remarks, that it often comes from a place of fear. And really being concerned for the loved one. So I think if we can join with guardians and parents around those things, the way that our daughter's team joined with us and said, what are you afraid of? And let's figure out what we can get into this plan that everyone's going to feel good about it. Right. So that collaborative dialogue can really make a difference to kind of getting alignment in the directions.
Can I add
guardianship doesn't.
Go ahead.
Go ahead, Amy. No, go ahead.
Well, and this is, it does go back to RAP, but I think it goes in this conversation. When I was working in the local community services, there were a number of individuals who had guardians. And so we actually offered a RAP seminar one that partnered the individuals with their guardians and actually went through the whole process there with them working kind of together and adding and like exploring these conversations. And as the individual is crafting the RAP, that guardian was right there with them, and they were doing it together. It was very interesting, and what came out in the end was really a crisis plan that I do think really reflected more of who I actually knew the individual to be, just because I was working with many of them in a peer support capacity. And so, yeah, just a little thing to throw out.
Yeah.
I'm just going to address just a technical question. We've dropped the link to the evaluation in the chat a number of times. I did it pretty recently because chat is pretty active here. Let me just remind you that in order to be eligible for your credit, you do actually have to submit a survey and give us your name and your email address so we can distribute it to you. And you're only going to have 2 weeks to do that. So again, if you don't get to it this afternoon, keep an eye out in your inbox. Give us it's a big group. We had close to 300, more than that, people today. So give us about 3 weeks to process all of them. And also check your junk or your spam folder. Again, the sender is going to come from a sender named Certifier. And please check that before you reach out to Anita Allen. The website is right there on the screen for you. So I just, first of all, I want to thank all of our co-presenters, folks that offered remarks today. Thank all of you for the thoughtful questions and insights that came into the chat. Our team that was working behind the scenes to help us with different technical issues and dropping links. We really appreciate everyone's efforts and time today. And keep in mind again, that a recording of the training as well as the full slide deck with the embedded resources will go out to everyone. Hopefully within a couple of weeks, you'll be getting that. So stay tuned for additional information. Okay. All right, we're going to go ahead and sign off, and I think a few of the folks from our team are going to hang on just to connect here. But again, thanks so much for your time, and we hope that you found the
Everybody.
resources useful. Amy, do you have a couple of minutes to stay on? I'm not sure, Robin and Justin, if you have a couple of minutes. Do you want to debrief now, or do we want to hold that for another time?
I have a few minutes now,
So do I.
Okay.
if that works for everybody else.
Yeah, it definitely does.
All right. Why
Right.
don't we do this? I'm wondering, it may take a little bit for people to log off, especially if they've stepped away at the end of the presentation. I'm wondering if it would work. Ingrid and Anita, can we just close out this meeting and rejoin? That makes some sense.
That sounds good.
All right.
Yes.
So we'll go ahead and do that. Again,
Okay.
thanks everyone for being with us today.
Bye-bye.
Thanks all.